My name is Leo Anthony Selly. I'm an intensive care physician at the Beth Israel Deaconess Medical Center and a principal research scientist at the Massachusetts Institute of Technology, or MIT. I'm here today to talk about the GOSSIS project. The Global Open Source Severity of Illness Score, or GOSSIS, is an international consortium that seeks to pool and coordinate resources to create a database containing a large amount of critical care data from many different ICUs worldwide. As its first output, GOSSIS aims to develop a new family of open source scoring systems for assessing the severity of illness of critical care patients. Severity of illness has been traditionally linked with mortality risk. However, the relationship of severity of illness with mortality likely differs across ICUs based on a host of factors, including but not limited to staffing, capacity for special diagnostic tests and interventions, and variation in the culture of quality and patient safety. While in theory, one would think that physiology transcends geography, differences in care systems and patient populations may translate the same score to very different outcomes. Put simply, an illness severity translates into different mortality risks depending on where the patient is located. This is problematic given that the two concepts are intrinsically linked in developing the score. Although these issues are understood in theory, an objective quantification of these differences is not possible without a validated severity of illness system developed from an international collaborative. It is essential to achieve a uniform definition of critical care severity that crosses the geographic, cultural, and medical borders of healthcare. Such a definition potentially provides a universally applicable value that can be used to prognosticate individual patients and compare tests and treatments across a variety of care access views. A requirement for improving critical care around the globe are tools for the continuous evaluation of ICU practices and performance. In a growing number of high-income countries, ICU registries have proven to be critical for monitoring ICU performance. These registries have been adapted to the more resource-limited setting and are maintained at relatively low costs, as demonstrated by registries in Argentina, Brazil, Malaysia, and Sri Lanka. Currently, a limited number of low and middle-income countries operate such registries. A wider rollout is likely to require support and mentoring from existing registries. This is because the main barriers for the commissioning of a new ICU registry network is a critical mass of ICUs that must coalesce, the cost and expertise necessary to develop a methodology, and the perceived need to agree on the geographical boundaries of such networks. Establishment of a transnational open source registry collaboration can enable an individual ICU, irrespective of location and with minimal expense or expertise, to become a new node in such a network. This process can be fueled, especially in low and middle income countries, by the adoption of an open source platform that will automatically extract data for benchmarking processes. Traditionally, ICU registries have gathered a retrospective minimal data set, either from electronic or paper systems, and applied standardized data processing algorithms to generate regular predefined benchmarking reports based on a validated prognostic model. However, with sophisticated electronic health information systems becoming the norm in high-income countries, and simpler systems slowly becoming more widespread and affordable in low and middle-income country settings, in combination with cheaper and bigger computational power and rediscovery of powerful machine learning algorithms, has allowed a more dynamic and immediate utilization of the data. Such information is then available to a variety of stakeholders, including clinicians in the contributing ICUs, administrators, and the wider public. Near real-time monitoring of nosocomial infections, antimicrobial resistance patterns, and surveillance for the early detection of epidemics could be important benefits of such systems, further amplified by the cross-border collaboration between these registries. The recognition of the need to better leverage data gathered by electronic ICU health information systems, especially to address research questions which are challenging to address with randomized controlled trials, has led to projects such as the MIMIC and the Philips MIT EICU Collaborative Research Database projects in the US and the HIC project in the United Kingdom. The current collaborators on the GOSSIS project are MIT, with MIMIC from the Beth Israel Deaconess Medical Center, Philips EICU Research Institute, the Australia-New Zealand Intensive Care Society, Orchestra, a project of the EpiMed from Brazil, and NICST from Sri Lanka. The project will be governed by a charter and a data handling arrangement and will be guided by a steering committee composed of members from the contributing networks. The project has no dedicated funding at present, and a medium-term goal will be to secure dedicated funding in order to achieve the project objectives. A project such as GOSSIS can be expected to encounter challenges common to any large health data project. In addition to the obvious difficulties in securing funding, the challenges of governance, data security, patient confidentiality, anonymization, data ownership, data transmission across borders, malicious activity, and unintended consequences of data analysis have been well recognized and are relevant to the project. The collaboration involves organizations and individuals who have experience in overcoming these difficulties at various levels, both in the public and private sector. The collaboration will develop best practice guidelines in keeping with industry and regulatory best practices, which will also be made publicly available to improve transparency and accountability. The collaboration will also test approaches to minimize data risks. For example, data can be retained in the original systems and share regular output from a common analysis script. The project will facilitate sharing of critical care patient data across participant countries and build a more collaborative and transparent research community with a focus on health data science. Finally, utilizing the diverse skills and technologies available to the collaborative, GOSSIS will encourage and mentor the deployment of suitable distributed data platforms, especially targeting ICUs that are not currently part of any registry. The GOSSIS project has the potential to revolutionize the way in which critical care registries and networks gather and share data in a truly collaborative manner in order to directly improve patient care, surveillance, and research. Thank you.